This is Sean McAllister for Anesthesia 4101. This is assignment 4, airway management submission. This particular case took place this past week during my cardiac rotation, where I spent a day working in the cath lab. This case occurred while I was working with Dr. Stefan Schwartz. The patient demographics: so this is a 65-year-old male who was presenting for AFib ablation with TEE monitoring. He had a BMI of 39 kilograms per meter squared. He's morbidly obese. He had a past medical history of hypertension, OSA where he was moderately compliant with his CPAP, and a previous end STEMI in 2017 requiring stenting of his left circumflex artery. This procedure and this patient were the first case of the day in the cath lab. I saw him in the holding area in the morning for assessment and IV access. Just sitting in bed in semi-Fowler's position, it was quite evident, even with the blankets and gowns, of how obese he was. He was apple-shaped versus pear-shaped. Apple-shaped, he had a lot of extra thoracic restrictive tissue really up around his chest area. Prior to go see the patient, I looked him up. There was no previous anesthetic records for him, unfortunately. During patient interview, he had a remote surgical history of a lap epi for which he was negative for a history of malignant hyperthermia. And then, as previously mentioned, he has undergone angiography for stenting of his LCA, which was done under sedation. His airway assessment revealed the following characteristics. He had a mouth opening of 3 finger breaths. He was a class 3 Mallampati with a large, wide tongue. He had a retrognathic jaw and thyromental distance less than 2 finger breaths. He had a poor class C mandibular protrusion. There was limited functional cervical flexion and extension. Upon further inquiry, he said he hasn't had any injuries like whiplash or C-spine injuries to limit his cervical flexion and extension, but functionally it was quite limited. And then on palpation of his thyroid notch, his cricothyroid membrane was quite difficult to landmark. After this assessment, I presented the patient to Dr. Schwartz, who also went out then and interviewed the patient and agreed with my findings. In discussion with Dr. Schwartz, our plan was still to induce the patient in the room on the fluoro table. This was an out-of-OR procedure, 2 floors away from the OR. There was no troop pillows immediately available, so I gathered enough bed sheets and pillows to allow for adequate ramp positioning of the patient, to align the tragus above the sternal notch, to better align the pharyngeal and laryngeal axes. I also prepared the Store CMAC with the D-blade handle and rigid stylet. The patient was adequately pre-oxygenated, requiring flows up to 15 liters per minute. He was able to do deep breaths, breath hold, and exhale. We also used a little APL for a little CPAP during pre-oxygenation. The patient was induced with remifentanil 200 micrograms, propofol 180 milligrams, and rocuronium 40 milligrams. Immediately available, we did have a 500 milligram vial of Sugamidex. Based on his weight, even the 500 milligram vial was not necessarily enough to meet the 16 milligrams per kilo for immediate reversal, but Dr. Schwartz felt like that would be adequate if we had to immediately awaken him. Post-induction, we immediately placed an appropriately sized OPA and began 2-person bagging technique. He held the mask and I was able to bag efficiently. After adequate time to allow for paralysis, Dr. Schwartz intubated the patient on first attempt with a grade 2B view. The larynx were quite anterior and did require manipulation even with the D-blade and rigid stylet. As well, his tongue presented an issue throughout the entire intubation for controlling the tongue to optimize view, as well as it limited ETT manipulation. Fortunately, as I stated, that he was intubated on the first attempt. There was no significant desaturation or hemodynamic issues. However, Dr. Schwartz did make an in-depth note, and he now has an electronic anesthetic record within Providence Health that he is a difficult airway. Thank you.